My name is TJ Gand. I am currently the chair of Department of Anesthesiology at Stony Brook. First of all, I want to welcome you to this morning symposium. It's early by Las Vegas standard, but I am proud that you're all here. This morning, we're going to talk about a topic that impacts all of us. If you are practicing anesthesiologist or anesthesia care provider, this is a topic that, unfortunately, we still see it. I hope that it's something of the past. I've been interested in post-operative nausea and vomiting over the past more than 20 years. And I always think that, one day we are going to be, PONV is going to be history, but after 20 years, we are still not there. But hopefully, we are striving towards a day where we don't see post-operative nausea and vomiting. That is always my dream. Anyway, so we're going to kick off, and this is my disclosure. Now, this morning, we're going to cover a few areas in post-operative nausea and vomiting, and also talk about the burden of PONV, and review some of the treatment options. Some of you may think that these are something that I learned at medical school during residency, so trying to refresh your memories. What are the drugs that potentially work in the post-operative nausea and vomiting arena? And also talk about how do we manage on a day-to-day basis. So there are a few learning objectives I just want to outline, understanding, first of all, the incidence and etiology, and risk factors, because I think that is important. If we know the risk factors, perhaps we can better predict who are the ones who are potentially more likely to develop post-op nausea and vomiting, recognizing the burden as well as talk about current approaches and some of the unmet needs. All right, let's take a look at the overview of this surgical landscape, because healthcare really has changed. 20 years ago, when I started in this country, is very different today than what it was in the early days. And it's constantly evolving, right? We are going from what we call a volume-based care to more value-based care. So the focus has changed. And now we talk about the triple aim of healthcare, where we put patient at the center of healthcare, because that is what we are here for. We are here to provide care for our patients, provide them with the best experience. The whole system, healthcare system, has also changed. Now we are focused more on quality, and we also focus on efficiency. Because what we really want is to try to achieve the best quality at the lowest cost. And that is what we call value. Now, many of you know, in this country, in the US, we spend a lot of money on healthcare. About 18% of GDP was spent on healthcare. And this is way above any of the countries in the world, at least 2 or 3 times. Now the question is, are we getting value for the money that we spend? I know that this meeting has got a lot of international audience. I was just talking to someone from Barcelona this morning, from UK, and again, you can see that the healthcare systems are very different. But the question is, are we getting value for the money that we spend? And I would say that there is also a fourth aim of healthcare, and that is provider satisfaction. This has been, I believe, overlooked for all these years. And now we talk about burnout, we talk about physician dissatisfaction, right? Physicians, healthcare providers leaving the healthcare industry because they are disillusioned, their everyday work is significantly harder than it needs to be. So this fourth aim, which I think is critical, that if we can have a healthcare that also helps providers to make it easy for us to carry out what we need to do to take care of patients is also critically important. All right, let's take a look at another aspect. How does the change in healthcare for the perioperative physicians, how can we contribute in that? How can we make the care better? How can we improve quality, reducing costs, and increasing value? And I think one of the very tangible way of doing that is what we call enhanced recovery. And those of you may have started enhanced recovery in your hospital, and enhanced recovery originally started in Europe, and it's in the last number of years have increasingly practiced in this country, because enhanced recovery, if you look at the elements of enhanced recovery, the intent of enhanced recovery is increasing value, and that is increasing quality, at the same time reducing costs. Now, enhanced recovery is a multidisciplinary approach. It involves surgeons, the anesthesiologists, nurses, pharmacists, everyone who touches the patient who comes through the perioperative journey. I believe that as anesthesiologists and anesthesia care provider, we have a major role to play in the success of enhanced recovery. Now, if you look at the various elements of enhanced recovery, and I just put up some of these that we, the anesthesia care provider, are the one to carry out these elements, providing anesthesia in the best way possible to make sure our patient wake up quickly after surgery and back to their baseline. Perioperative fluid management, something that we do every day, but I can tell you that we are still not very good at it. Pain control. This meeting is about pain control, right? We are all here to learn about how can we provide the best pain management. And that is owned by our specialty. And that is a critical element of enhanced recovery. Because what we do in the operating room, I believe, can impact post-operative recovery. By minimizing opioids, you can allow patients to eat and drink earlier after surgery. By minimizing or using short-acting anesthetic, preventing nausea and vomiting, patient can then mobilize post-operatively. The earlier the patient mobilized, the earlier they can get out of hospital, the earlier bowel function returns. So we have an important role to play in enhancing patients' recovery. And often we underestimate the importance of what we do in the operating room impacting post-operative recovery. So what we do in the operating room can significantly impact post-operative outcomes. And we also know that if patients develop complications during their hospital stay, even up to 30 days following surgery, number one, the patient stay in the hospital longer, cost goes up. I can tell you satisfaction certainly goes down. So this is important for us to recognize what we do impacts not only the patient, but also the cost of healthcare delivery. Now, those of you who practice in the US know about this merit-based incentive payment system, or the acronym is MIPS. Now, anyone in the room participate in MIPS? You can put your hands up. I can see a few hands up. So this is a CMS mandated merit-based incentive system. And the intent, I believe, is a good one, right? Because they tie payment to quality and cost effectiveness, as we talked about. It drives improvement in care processes and health outcomes, and ultimately reducing costs. So the intent is good ones. But sometimes because the way it's implemented, the way it's collected, it is not quite as straightforward. And obviously, as anesthesia care provider, we try to strive for the best quality because these are all tied to payment. And those of you who participate in MIMS know that this year and next year, potentially 7 up to 9% of your Medicare reimbursement will be affected if you do not do well in this merit-based incentive payment system. And it can impact your bottom line if your Medicare population forms the bulk of your practice. Now, within that MIMS, there are a number of processes or a number of outcomes for anesthesia. And one of those is post-operative nausea and vomiting, focusing on how can we reduce the incidence of PONV. Now, we know that it is sometimes difficult, despite your best effort, to abolish post-operative nausea and vomiting. So the MIMS system simply said that if you have a patient who, based on the risk factors, which we'll talk more about, under the high-risk category, are you providing appropriate multimodal antiemetics therapy? So that is 2 and above. Now, if you fulfill that, then you fulfill the additional incentive payment. Now, you may think that, well, that is simple to do, right? I look at the risk score. If they got 2 or 3 risk factors, I just give them multimodal antiemetic therapy. Now, while you may feel that as an individual you have impact on that, but as a system, it's not quite as easily as you think to achieve that because everyone has to adopt that incentive system and everyone has to provide 2 or more antiemetics for high-risk patients. All right, let's take an overview of the post-operative nausea and vomiting. It is common. As I mentioned earlier, I still see it on every day when you practice. And it is a concern for our patients. In fact, in many surveys, patients would rather have some pain. I can take some pain, but I hate to be sick. And that has consistently, survey after survey, that's what patients tell us. This is just some of the anecdotes from patients about their experience of post-operative nausea and vomiting. And some of you, if you read through it, it's very real. Imagine yourself as a patient following surgery who just had a big surgery and you're in pain and at the same time you are throwing up. And that is, from the patient perspective, the greatest dissatisfier following surgery. And as you can see here, it impacts on recovery in the PACU. Nausea was on top of pain. And when you have pain and nausea, it's even worse. And then one patient said, absolutely impacted my recovery. And they told me that I was going to stay for 2 days, and I now have to stay much longer. So it takes for us then there are ways to prevent it. We just need to be more cognizant about what does that mean to have nausea and vomiting in our patients. So we talked about nowadays with a lot of antiemetics that incidence of nausea really should be minimal. But if you look at studies, surveys, it still happens commonly. It's estimated on average 30% of your patients will develop post-op nausea and vomiting. These are all comers. And in high-risk patients, even up to 80%. So it's extremely high. And we know that if you have a patient who, unfortunately, following ambulatory surgery, because of nausea and vomiting, cannot be discharged, if they stay in the hospital, overnight hospital cost is extremely high. And that in itself it's well worth to think about, can we better provide prophylactic antiemetics to prevent patients from having to stay back in the hospital. As I mentioned earlier, patients always tell us that nausea and vomiting is something that they really hate to experience after surgery, even more than pain, as this survey demonstrated that PONV is the most common reason for poor patient satisfaction. 50% of the patients that said that nausea and vomiting is far worse compared to pain, about 27%. Now, those of you who put patients on PCA following surgery and you see them post-operatively, you get a call from the patients that the patient tells you that they have 10 out of 10 of pain. And the patient, when you go and see her, she has a PCA button in her hand, and you looked at the PCA machine. The last time the patient pressed the button was about half an hour ago. And you said to the patient, well, if you're complaining of pain, there is the pain button. When you press the button, you get a dose of painkillers. Why don't you press the button? And now the patient begin to tell you that the reason why this patient did not press the button. So we were interested in this question because patients constantly trading off between giving themselves painkillers at the same time titrating their pain, right? And when we ask patients, why is that you don't press the pain button until the pain goes down to zero? And you almost never see patient on PCA tell you pain is zero. And it's because there are potential side effects when they press that pain PCA button. Whether you use fentanyl, hydromorphone, morphine. And this study shows that patients would rather have some pain, but they hate to have the side effects as a result of the drugs, the opioids, when they press the button. So when we give them a scenario between whether you would want to have good pain relief that come with it moderate vomiting because of the side effects of the drugs, or just fair pain relief, but with no side effects. Overwhelming majority of patients say, I would rather tolerate some pain, but I hate to have the side effects. Same goes with constipation or itchiness. So patients constantly trading off between efficacy of analgesia at the same time of side effects profile. And that's why PCA patients almost never get down to pain score of 0. It's always between 3 and 4. They say, I can live with that, but I don't like some of these side effects when I press the button. Post-op nausea and vomiting also, because of opioids, we see a lot of post-op nausea and vomiting. Now, if you have a opioid-sparing strategy using multimodal analgesia, your PONV score typically reduces. But again, this study shows that you still see some post-op nausea and vomiting. So it's not all due to opioids. And there are some other factors that can also promote PONV as well. Now, sometimes we wonder, if I were to have a great antiemetics, right? The antiemetics that I'll give you would prevent nausea and vomiting. Would our patient pay for it? What is the willingness to pay for an effective antiemetics? So we did a study a number of years ago asking patients who had surgery in a PACU and asked them, how much would you be willing to pay for an effective antiemetics? And interestingly, we found that those patients, all comers with no nausea and vomiting, they say, I would pay about $55 or so on average for an effective antiemetics. And those patients who had nausea went up. I'm willing to pay over $70 if you can give me a dose of antiemetics that would treat my nausea. Those who have vomited went up even higher. So that shows that it is something that a patient really want to avoid, and also even willing to pay for it. And this willingness to pay study is very commonly done in other industry, but somehow in healthcare, it almost seems like taboo when you mention dollars and cents. But if you ask patients, they are willing to pay for that if there's an effective drug. We know that although rare, post-op nausea and vomiting can lead to even more severe problems. And these are some of the reports that we see in the literature on the consequences of untreated or severe nausea and vomiting. Electrolyte imbalance, because they keep throwing up, can potentially hurt their surgery, especially plastic surgery. If you have a facelift, the surgeon just done his wonderful job, and then you begin to retch in the PACU. If you are the anesthesiologist, I don't think the surgeon like you that much. Respiratory complication, aspirations. So there are complications potentially as a result of nausea and vomiting or retching. Now, it also results in increased length of stay. And this study again showed that if you don't have nausea or vomiting, your mean length of stay is fairly consistent. For this study is about 3 days. And once you have vomiting, you have confusion, you have constipation, your length of stay goes up. So that is where potentially we can save healthcare system some dollars if you can reduce the length of stay by avoiding some of these, many of them opiate-related side effects. Cost. We work in the operating room. We know that nausea and vomiting increase costs, and it also increased the cost when the patient stay in the PACU longer. Now, perioperative environment is associated with a very high cost value. It's estimated that for PACU time, every minute is about $6. OR time is even higher, estimated $35, $37 per minute. Could you imagine that if you can reduce the length of stay in the PACU, and again, I don't know about your hospital, my hospital PACU is always full. We always have PACU whole. So imagine that if you can have impact on patients leaving the PACU sooner, and therefore the patient can then, from the OR, come to the PACU, you can save significant amount of dollars, $36 per minute. Every minute you delay the patient going to the PACU from the OR, you are wasting a lot of resources. Now, risk factors. We do know who are the patients who are more likely to develop nausea and vomiting. And these risk factors have been well studied. I classify them under patient, anesthesia, and surgery. There are many of them, and sometimes it's tough to remember all the risk factors. So over the years, there have been some attempt to trying to identify what are the most important risk factors. And some of these scoring systems, as this one by Christian Napfel, basically saying that of all the risk factors, and they are important, but if you can remember just 4 important ones. Being female, you have 3 times the risk for developing nausea and vomiting compared to men. History of PONV, or motion sickness, a very predictive risk factor. If someone tells you that, doctor, and every single time I have an anesthetic, I throw up. And those are the patients, if you don't do anything about it, guess what? It's very likely you're going to see the patient throw up again. Now, but if you develop a strategy and say, okay, I'm going to do my best, and I won't promise, but I'll do my best to make sure that you don't throw up again following this surgery, and if you do appropriate management, and if the patient have good outcome, they always thank you and said, can you give me the recipe? Because I'm going to take it with me in case I have surgery again, I can pass on this recipe to my next anesthesia care provider. Non-smoker, interestingly, is a risk factor. Not that I would advise my patient to start smoking. And interestingly, Short-term smoking does not reduce the risk. You've got to be a long-term smoker. We know opioid use is a significant risk factor. Now, if you remember these 4 risk factors, the more risk factors the patient has, the higher the incidence, up to 80% if you have all 4 of these risk factors. So there's something we can do about. Let's take a look at some of the available therapy as well as what is the mechanism. And again, broadly speaking, PONV is mediated centrally as well as peripherally. So this higher cortical centers can impact on PONV. The vestibular system, as a result, when you go sailing or you go jumping out of a plane and your vestibular system get disturbed, you get nausea. And we also know that the chemoreceptor trigger zone is an area which is in the base of your 4th ventricle, is very porous. So theologically, the purpose is that any of the toxic chemicals that you ingested inappropriately or that feed to the chemoreceptor trigger zone and vomiting center. And also peripherally. Again, if you swallow something that is, when you're not meant to swallow it, you will throw up, right? That is the peripheral mechanism of vomiting, nausea. So it is mediated both centrally and peripherally. And in the chemoreceptor trigger zone, there are a number of receptors. And these serve as a little reminder to you, some of these receptors are involved. Acetylcholine receptors, dopamine receptors, histamine receptors, 5-HT3 or serotonin receptors, and more recently, the NK1 receptors have been implicated as the major receptor system within the chemoreceptor trigger zone and the vomiting center. So most of the drugs that we use today act as antagonists on one or more than one of these receptors. So if you look at, in the context of enhanced recovery protocol, where you have a number of stimuli that can provoke nausea and vomiting, and there are a number of strategies within the enhanced recovery protocol that try to reduce that risk of post-op nausea and vomiting. For example, using short-acting anesthetic agents, avoiding opioid by using peripheral nerve block, epidurals, that I'm sure you learn a lot from this meeting here. Nutrition is important, avoiding sodium fluid overload, giving patients antiemetic therapy. So all these things reduce the incidence of PONV. And there are these classes of drugs that I showed you earlier that act on these receptors that has been shown to be effective in managing post-op nausea and vomiting. Now, we also know because of 5 receptors are involved, so we have no idea which receptor is implicated in a particular patient. As a result, by using combination, drugs that work on more than one of these receptors, in many studies have shown to have increased efficacy. So this notion of combination antiemetics should be thought about in every single case, because monotherapy will only reduce the risk by a certain amount. But if you want to reduce it further, you need to combine drugs that act on 2 or 3 of these receptors. So this combination involving 2 or 3 antiemetics really should be the guide for high-risk patients. So if you think about how do I manage a patient when I see them in the pre-op holding area? So first of all, think about the risk factors. How many risk factors do our patient have? And also, don't forget about patient preference. We talk about this new healthcare system where patient should be in the center. And sometimes we don't ask the patients. And also about the type of surgery that the patient is undergoing. Maybe some surgery you really do not want the patient to throw up. Facelift, eye surgery, neuro procedures, where increased retching and vomiting can increase intracranial pressure. So those things has to be considered when you are managing how do I best avoid post-op nausea and vomiting. And then think about how can I reduce what we call the baseline risk. So in other words, by adequately hydrating the patients, by potentially reducing some of the drugs that provoke nausea and vomiting, opioids, for example. And then beyond that, think about appropriate antiemetics prophylactic therapy. This is the SAMBA guidelines, which was last published in 2014. We are upgrading the guidelines as we speak, and essentially give you a guide on how to manage these problems. Screen patients for risk factors. Number one, using combination antiemetics, avoid nitrous oxide, avoid GA, mainly because of volatile anesthetic. In fact, intravenous anesthesia, which is more widely practiced in Europe, propofol is an antiemetic. And if you use propofol as the base of your anesthetic, you can essentially treat that as giving one antiemetic. Minimize post-op opioids, provide adequate hydrations. Guidelines. Society provide guidelines and encourage people to follow the guidelines. So as you can see here, if you come from an institution that have the guidelines and actually implement it, you are compliant with the guidelines, your institutional nausea and vomiting incidence will go down. And this is something that your administrator would really appreciate what you do. And it has been shown that if you were to comply with the guidelines, whether it's the SAMBA guidelines or whatever guidelines, your incidence of PONV as an institution will decrease. Now let's talk a little bit about treatment, because we have a lot of drugs that we use for prophylaxis, but what about treatment? Because of the various receptors involved, if you give a drug that occupies one of the receptors, let's say serotonin receptors, ondansetron, a very common drug used for prophylaxis, and if the patient in the PACU develop nausea and vomiting, is it worth to give ondansetron again? And the answer is no. As this study shown, in this study, every patient was prophylaxed with ondansetron, and then they developed nausea and vomiting in the PACU, and they randomized them into a group that received ondansetron again versus a group that received placebo. And they found there was no difference. So that suggests that if you give ondansetron as a prophylaxis, repeating ondansetron as a treatment drug does not work. So you need to move to a drug that acts on a different receptors. And there are a number of these drugs. However, we are fairly limited by the number of antiemetics we have. So let's just go down this list of potential antiemetics that we can use. 5-HT3, as I mentioned, if you use 5-HT3 in your prophylaxis, it doesn't really work for treatment, so that is not a drug to be considered. Metoclopramide, unfortunately, while it's a good drug to empty the stomach, but it's not a very good drug as a direct antiemetic because it doesn't work that well. You need to treat about 20 patients to have one patient that would benefit from giving metoclopramide, at least at a 10 milligram dose. Dexamethasone, a great drug for prophylaxis, but is not a very good drug for treatment because it's slow onset. It doesn't work straight away, and when you have patients who are suffering from nausea and vomiting, you don't want to give a drug that works in 4 hours. Promethazine, a drug that works on multiple receptors, on the cholinergic, histamine, as well as dopaminergic receptors. But there's also an issue with promethazine. As many of you know, that there's a warning about promethazine when you not inject it in the IV, it can cause tissue necrosis. And there have been reports that patients have to have their limbs amputated because of this tissue sloughing when the drug is out of the vasculature. Dopamine, a great drug, shown to be effective. Dopamine antagonists such as droperidol. Unfortunately, droperidol had a black box prolongation of QT intervals. And that really significantly impacted on the use of droperidol as a routine antiemetics. Dimenhydrinate, histamine antagonist, good drug, but it also comes with sedative properties. Aprepitant, an NK1 receptor antagonist, good for preventing vomiting. Unfortunately, is only available in an oral formulation, and therefore is not the best option when the patient is actively having vomiting or nausea. So there are some limitations on every of these potential options that we can use. So we are a bit limited by the choice of antiemetics when the patient needed it most. They had a prophylaxis, now they're throwing up. The nurse is looking at you and said, "Doctor, do something." And you're scratching your head and say, "Well, you know, this drug has some side effects, I have problems. What do I do?" So there's clearly a need for developing additional antiemetics that can potentially could be used when the patient failed their prophylaxis. So because of these many pathways, so PONV is not as simple as just giving the drugs or giving 2 drugs. There are multitude of factors to consider. And as I mentioned earlier, patients still experience PONV. And we know that ondansetron is very inexpensive, it's generic, it has its place, but it also has some limitations. Likewise, droperidol is also effective, but it also has some problems with QTc prolongation. And we talk about rescue, there is also a shortage of additional drugs that we can potentially use. So the bottom line is that there are opportunities for we to do better. What can you do when you go back on a Monday, back to your routine practice? There is something you can do. Number 1, think about how can we best treat my patients? Evaluate, does your institution have a protocol? If your institution does not have a protocol, maybe you can help formulate one. Given the information that I share with you today, you have a lot of information. You know what are the risk factors. Start off with that. You know the drugs that are effective. You can put in a protocol, these are first-line antiemetic prophylactic therapy. Use combination in high-risk patients. And you can also know that if you fail the prophylactic antiemetic therapy, what are the treatment options? So you have all this information that you can put together, and ultimately, if you are not doing an enhanced recovery protocol, I would encourage you to go back to an institution, talk to your surgeons, talk to the nurses, come up with a team that can then implement enhanced recovery, and I can tell you that it's very rewarding because you will see an improvement in your patient care. Also, you will help your institution in reducing healthcare costs, improving quality, improving patient satisfaction. Thank you very much for your attention.